Okay, looks like it's time for us to get started. Um, gonna just pull up my introduction slides here a minute.
Okay. My dog's upstairs.
And I just see someone wrote in a question, does this presentation start at 1 p.m. Eastern Time or 2 p.m.? It looks like the time info is different in the support box versus the emails that went out today. Sorry about that. So it our system, Adobe Connect system, the time that we set up for it does use our local time here in um, in the central time zone, and so I apologize if that's confusing. And I try to give information on that so it um, for each time zone, but it may have been incorrect somewhere. But we are starting now at 1 p.m. Eastern, or 12 p.m. here in Central Time, 11 a.m. Mountain, 10 a.m. Pacific, and 9 a.m. Alaska time. And that is the time that we regularly hold our webinars twice a month. So um, oh, I see. Oh, I do see below it where you're mentioning. Um, so I apologize. I'll fix that there. I think I had changed that last week when we had another webinar series that started at a different time. So thank you for pointing that out, and I'll get that fixed here. Um, my slides are still uploading, so I'll just start by saying that I'm Kate Trams, and this is the National American Indian and Alaska Native Addiction Technology Transfer Center. This is our behavioral health webinar series, and today we have Dr. Maureen Liliskoff here to talk about women, women's health, specifically women with substance use disorders, what we know about that, and how we can help them. So once my slides come up here, let's see. Okay. Um, so this training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, as I mentioned. We are part of the ATTC network, which also includes 10 regional centers and a network coordinating office. To learn more, please visit our website, which is attcnetwork.org, and you can add the /native to get right to our site on there. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs for a $15 fee. The CEU request form is available for download in the Files pod in the webinar screen, and we will also be sending this form in a follow-up email to all who attended. Immediately following today's webinar, you will be redirected to our GIPRA evaluation. SAMHSA asks us to evaluate our events in order to provide improved performance assessment and accountability. The survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar, so please use our chat pods to share questions and comments, and we will have some time at the end where we will respond to questions. So we'll watch for those throughout, and then we'll have some time at the end where we can address those. Today we're having Dr. Maureen Liliskoff here to present on women's health, and Dr. Liliskoff created the Excel Research Consulting firm in 2010 to help organizations and individual communities around the globe create and sustain cultures of health by increasing their awareness and knowledge of social contexts, behavior, and lifestyle changes that promote disease prevention, treatment, and management. She has had years of experience working with tribal communities, particularly in Iowa, Nebraska, and South and North Dakota, to prevent chronic diseases that include alcohol and drug abuse and their related consequences. So, um, with that, I am very excited to welcome Dr. Liliskoff here. She is a great person to be speaking on this topic, and I'm just glad we get to have her with us. So, Dr. Liliskoff, I'll pass things over to you at this point.
Thank you, Kate, and thank you everyone for participating on this webinar. As Kate has said, my name is Maureen Liliskov, and my background is in community and behavioral health and health communication. I typically like to preface a lot of my presentations by acknowledging my own biases. As she's mentioned, I was born and raised in Kenya. I went to graduate school in Iowa. I'm married to an American of Norwegian descent, and I've done a lot of work in Indian country. English is actually my third language, and I have traveled quite a bit and live in South Dakota, where some of my family members are still not convinced I live in America. I should technically be a poster child for cultural competence, but yet every day I meet people, and even the same people, and realize just how incompetent I really am. And usually, when I tell people I'm from Kenya, their first comment or question has to do with how hot it is and how the winters must be difficult for me. Um, so we really all do have stereotypes about people, places, or jobs and or cultures that make us think something about them. But today we're here to celebrate all those differences and identify different ways that we can work with the women that we serve and who struggle with substance use and mental health disorders. So, in that vein, I'd also like to apologize in advance if I use language that might appear to be offensive or culturally insensitive. It's not my intention, but I do hope we can learn together as we serve the women in our community. While this presentation is for women in general, a lot of my reference will be with Native communities because that's the main population served by this particular ATC. And so, with that in mind, I'd like you to take a few minutes to put in the chat box some strength-based words to complete the sentence, women are. Women who come to our program are. And if there's a word that has already been used, find another one. Strong, brilliant, powerful, empowered, or unique, important. Fierce, love, very strong words for the women we know and the women we work with. And so, this, as we go through this presentation, I'd like you to think of those words and think of the women you know and the women who come to our programs and our clients. Those will guide how we treat them. So for this presentation, we'll talk about women's substance use disorders, delve a little bit into the prevalence of substance use disorders across the lifespan, hone in on special groups like the LGBTQ, military women, and ask an expert.
Maureen?
Yes.
Sorry to interrupt, but it seems like your sound is cutting out every once in a while, and so I wondered if you might try one thing up at the microphone icon.
Uh-huh.
If you click on the down arrow and you can select adjust microphone volume.
Does that sound better?
That sounds good, yes. Thank you.
Okay. Thanks, Kate. So we'll go through co-occurring disorders, some physical disorders that women experience, and then we'll talk a little bit about prevention, assessment, and treatment of women with substance use disorders. So once upon a time, treatment of substance use disorders in women was burdened by a lot of stigma. Um, and while it's way better, we still have a lot of work to do. And I can say that in many cultures and countries, it's still frowned upon, worse yet, not even talked about. The risks for substance use and substance use disorders are best understood by looking at the cultural context of a woman's life. When working with American Indian and Alaska Native women, for example, it's important to determine their cultural orientation. Are they traditional? Are they bicultural? Or are they assimilated? Those orientations really impact their worldviews, their cultural identity, their self esteem and self concept, their self confidence and self efficacy. So, understanding cultural differences among women is very vital to designing and implementing effective treatment programs and services. Um, like I said, I'm not culturally competent. In fact, I prefer to use the word culturally aware. And so it's important that our staff are culturally aware and recognize individual and group strengths and resiliencies that can help women from diverse cultural groups during treatment and recovery. Culturally responsive treatments improve short and long term outcomes. Should I call in? Would that be better, Kate? I see I still
Yes,
have.
we could try that. I'm wondering if it might just be that there are times if you might turn away from the microphone or something, but we could have you call in too if that seems
I'm as close
seems
as I can be. Let me try and keep going and see what happens.
okay. Thank
Um,
you.
if it keeps cutting out, I'll call in.
Okay, great. Thank you.
This next slide compares women and men and substance use disorders. And in general, women have lower rates of substance use and substance use disorders than men. As you can see from this slide, the past year illicit drug use among individuals 12 or older, the men had a higher rate than the women did. And by race, Native Hawaiians actually had a higher rate, not too far off compared to the American Indian population. And then the past year, alcohol use disorders was also higher among men than it was with women. Sex and gender differences therefore mean that women have way different experiences than men. And women generally differ from men in their pathways to substance abuse, the risk factors for use, the consequences of use, barriers to treatment and recovery support needs. Some of the risk
Or
factors. Uh huh. Colin.
sorry, I
Okay.
think we might have you call in because it does seem like it's still going in and out. So
So,
um
do I need to
yeah, so
disconnect
if you
my microphone?
see the the 800 number is in the contact and support notes below.
Okay.
It's 800-832-0736, and then you can put in the room number um, as it's written there, star 4700964 #. And then when you do that, you'll just want to make sure you turn the computer sound off.
I apologize.
Not at all. It
Disconnect my microphone then.
yes. Yep. Yeah. I know it's unfortunately like technical issues are always a possibility. So thanks for being flexible. Okay, thanks for your patience, everyone, and hopefully we get Dr. Lilliscuff back on here in just a moment. Okay. Dr. Lilliscuff, are you there?
I'm here. I'm here. I'm here. I'm here. I'm here. Oh my God. That better?
Yes, there we go. Sorry, I was didn't have
Hello?
a good moment but yeah,
Hello?
sounds like maybe now you've turned your computer
Hello?
speakers off. Dr. Lilliscuff, can you hear me?
Can you hear me?
Yes, I can hear you. Can you hear me?
Every time I unmute.
Okay, Dr. Lilliscuff, it sounds like we could hear you and then it sounds like maybe you were turning your computer speakers back on, and that's why we were getting an echo. Um, but if you're using your speakerphone, um, hopefully you can hear me through that and not through your computer speakers. So I muted you, but now I'm gonna unmute, and hopefully that will work. Okay, Dr. Lilliscuff, are you there?
Can you hear me now without the
Yes,
echo?
I can hear you. Yep, no echo. Can you hear me?
Awesome. Thank you. All right. We can continue. So I was going to talk about some of the risk factors, and the main 4 risk factors, I'm sorry about that sound issue, are relationships for women. Women are strongly influenced by familial substance abuse, friends or partners. Co-occurring disorders are more likely for women with substance use disorders than they are with men. And so particularly mood disorders, anxiety disorders, and eating disorders. Past trauma is more likely for women, including rape, sexual assault, intimate partner violence, and among American Indians, historical trauma is also huge, and there's literature out there on historical trauma and how it's affected the American Indian communities. Prescription drugs are another risk factor that leads women to use substances. They're more likely than men to be prescribed addictive substances and to become dependent. Other additional factors that we need to pay attention to when these women come into our clinics include easy access, lack of positive activities, sometimes a home, in some communities, poverty, low education levels, relationship loss, just important things to pay attention to. So what are some of the standards, or what has been defined for light, moderate, and heavy drinking by women? For women, binge drinking is defined as 4 or more drinks in one sitting, compared to men's 5 or more drinks in one sitting. And moderate drinking by women is considered 4 to 9 drinks per week, and heavy drinking 10 or more drinks per week. And to understand those equivalencies for alcohol, when these clients come in, when they say, I've had a glass of wine or a can of or bottle of beer, those are equivalent, they're equal. And so if someone says, I've had 1 glass, the question is, what size of glass? So we don't just take it at face value, or I only have 3 shots. Well, 3 shots is equivalent to a glass of wine. And so understanding what they really mean when they say this is how much I drink is very important in helping to develop those programs for them. Now let's talk a little bit about the prevalence of use across the lifespan. So we have different women, different age groups that come into our programs or clinics or community programs. For instance, Jenny is 16 and smoking marijuana. Her needs are different than Chalisa, who's 70 and is dependent on alcohol. So understanding that each woman has different assessment, treatment, and recovery needs is key to getting the right treatment services for that particular woman. According to the Centers for Disease Control, from 1999 to 2010, yearly prescription opioid overdose deaths among women increased from 1,287 to 6,631. So that's a 400% increase over 10 years and amount to approximately 48,000 women who've died of prescription pain reliever overdoses between 1999 and 2010. Heroin use among women increased 100% between 2002 and 2013, compared to an increase of 50% among men. Women are more likely to have chronic pain, be prescribed prescription pain relievers, be given higher doses, and use them for longer time periods than men. And they're also more likely to become dependent on prescription pain relievers. So those are important factors that show those major differences. For many years, treatment of women was based on research on men. And obviously, when you look at those kinds of numbers, those were not working well for women. From 2000 to 2009, the use of opioids during pregnancy increased from 1.9 to 5.3 per 1,000 hospital births. So let's look a little bit about drug use among adolescents. So in this graph, you can see that among adolescent girls and boys ages 12 to 17, girls are more likely to use alcohol than illicit substances. It's more or less the same, but more women use alcohol than do boys. In general, men have higher rates of alcohol use, including binge drinking. But there's one exception. Girls 12 to 20 years have a slightly higher rate of alcohol misuse and binge drinking than their male counterparts. So these are your middle, high school, and college age women whose needs obviously differ significantly from those of men. And boys in all age groups are more likely to use marijuana than girls. But more girls are likely to use non-medical psychotherapeutic drugs like pain relievers, tranquilizers, and sedatives. Data from the Behavioral Health Barometer in 2015 again shows the marijuana use being higher in males than it is in females. And in males, it's much higher than it is for the national average. And marijuana use is significantly almost the same in the races, except for the Asians, but highest among the American Indian population. So when working with young women, it's important to consider the physical changes, hormonal changes, neurological changes that affect how they process substances that they use. Early onset of alcohol or drug use predicts later dependence in both boys and girls. And so those prevention efforts in our community are very crucial at a young age. High novelty seeking behavior in boys predicts early onset alcohol use, and sexual abuse in childhood is the strongest predictor of chronicity and dependence for women. Gromberg in 1994 came up with a description of some specific factors for women across the lifespan. And one relevant risk factor for adolescent girls is behavior problems like antisocial or aggressive behavior or deviance like shoplifting, vandalism. School absences and low educational aspirations have also been cited as possible clues to problem drinking among adolescent girls. So when working with young women, and we see sometimes in some of our American Indian communities, there's a high dropout rate. So keeping those kids in school, developing programs that prevent them from staying out of school, and just working with them to build that strong resilience and participation in community activities is very important. As girls mature, their maturation is also associated with depression or low self-esteem. And the big thing we know is bullying, both physically on ground and electronically. And so being observant of some of those issues among our young kids is very crucial in developing treatment programs that will help them stay sober. When it comes to women of childbearing age, again, that college age, women appear to drink more often and in larger quantities than they do after graduation. And that might just be a lifestyle thing. Single, divorced, or separated women may also drink more frequently. Women with reproductive disorders, e.g. those that are not able to have kids, may be at risk for drinking. So again, when these women walk into the clinics, when they walk into your community programs, it's important to delineate some of those issues that are very individual and specific to them. Drinking and substance use in pregnancy is also something we have to really pay attention to. 9.4% of pregnant women ages 15 to 44 have reported alcohol use, and 2.3% report binge drinking. Current alcohol use is generally lower among pregnant women during the second and third trimesters than the first. And that might be due to not knowing they were pregnant in their first trimester. So, and a lot of them, once they find out they're pregnant, stop using those substances. Tobacco use has also been known to lead to low birth rates for women that are pregnant. That number, the number of women with opioid use disorders at labor, quadrupled from 1999 to 2014. So, obviously opioids are hurting our communities significantly, and that's something we need to address. Among older women, although this is really culturally based, many women see their loss of youthfulness, being empty nesters, not being able to acquire new roles, may lead some of them to be depressed. And so not too many studies out there on older adults, but retirement might be a stressor because of loss of social networks, especially for women. And so while the rates of illicit drug use among women is generally low, we do see some prevalence of problem drinking among older adults and among older women from 1 to 8%. The tolerance for alcohol decreases with age, which also increases their risks for physical injuries or not being able to perform effectively. They have an increased sensitivity to alcohol and a higher risk for alcohol problems. Again, older women are more likely to be prescribed benzodiazepines, barbiturates, and antidepressants, which if they're drinking, there might be interactions. Now I'll switch focus to some special populations like the LGBTQ, and I like to say that for the Two-Spirit has been included in this definition to account for Two-Spirit populations among American Indian communities. Sexual orientation is associated with higher levels of emotional stress. The coming out process needs to be taken very seriously by providers, and they need to offer resources and support for their clients in the coming out process. Lesbian and bisexual women are more likely to consume alcohol and in greater amounts than heterosexual women. Alcohol, marijuana, and prescription drugs and tobacco are more likely to be used by lesbian and bisexual women. A lot of lesbians and bisexual women also report more depression, phobias, and PTSD. So these kinds of findings suggest that prevention and treatment programs should address substance use among these populations. Adolescent females and women who are struggling around their sexual orientation or experience prejudice are at greater risk of initiating and maintaining substance use. According to SAMHSA in 2009, only 6% of substance abuse treatment services offer special programs or group therapy for lesbian women. So that might be something that as community programs, as treatment programs, we work with our communities to develop, especially for adolescent women as they grow, to prevent use in adulthood. And some of the reasons why there might be higher rates of substance use among lesbians is because of punitive or traumatic reactions from parents, from family members, from caregivers in relation to their sexual orientation. SAMHSA's Tip 51 recommends that substance use staff explore coping styles and enhance coping skills to help these individuals manage stress associated with self-disclosure and the coming out process, and to deal with feelings of alienation from family members and other community members. Our military has about 15% women in the armed forces, according to the Office of the Deputy Assistant Secretary of Defense. And military sexual trauma is something that's commonly reported among women veterans. Department of Veterans Affairs data shows that 1 out of every 4 to 5 women veterans experiences military sexual trauma, which is associated with substance abuse and psychiatric disorders, including depression, anxiety disorders, and PTSD. On average, more than 7% of veterans report substance use disorder, and younger veterans are more likely to have a history of substance use. So even though more men than women veterans are treated for substance use, the number of women veterans admitted to treatment programs has been on the rise. More than half of the women veterans in these programs are treated for alcohol abuse, more than a fifth for cocaine use, followed by opiates, marijuana, and other drugs. And so one benefit that military women have is their work experience through the military service. They have specialized advanced training, and all these are important tools that can be used in helping them find employment after treatment and recovery services end. I'd like to, in talking about American Indians and Alaska Native women, I'd like to read an excerpt from an article that appeared in one of our daily newspapers. And it was a 4-part series examining the problem of missing and murdered Native American women. The searchers rummaged through the abandoned trailer, flipping over a battered couch, unfurling a stained sheet looking for clues. It's blistering hot, and a grizzly bear lurking in the bush unleashes a menacing growl, but they can't stop. Not when a loved one is still missing. Ashley Heavy Runner Loring, a 20-year-old member of the Blackfeet Nation, was last heard from around June 8, 2017. Since then, her older sister Kimberly has been looking for her. I need to do this, says Kimberly. I don't want to search until I'm 80, but if I have to, I will. Ashley's disappearance is one small chapter in the unsettling story of missing and murdered Native American women and girls. No one knows precisely how many there are because some cases go unreported. Others aren't documented thoroughly, and there isn't a specific government database tracking these cases. These are just some of the issues that our Native American populations deal with. And when you look at some of this data, among current female drinkers, 31% were most likely to have had at least one heavy drink a day. American Indian females 18 and older are more likely than the national average to report past month illicit drug use. In 2009, the females had the highest drug and alcohol drug-induced death rates compared to other races. Age-specific drug-related deaths were higher among American Indian females residing in IHS areas. Native Americans have some of the highest rates of fetal alcohol spectrum disorders, and some of these issues in Indian country are related to oppression, displacement and loss of self-determination, trauma, poverty, and inadequate access to health care. So when Ashley's sister Kimberly comes into treatment, she's not just dealing with her alcohol or drug abuse. She's dealing with loss of her sister or a missing sister that she has no idea where that sister is. And that's its own level of trauma. So understanding our clients up to that basic level is very important in developing treatment and recovery services. So taking them as a whole and including all that information about them in the treatment and recovery process is very crucial. This same article talks about a Kansas professor, Sarah Deer, that says Native women have long been considered disposable, and that's made them a target, or particularly for the women who have addiction issues, PTSD, and other kinds of maladies. So understanding those levels is very crucial, and not for Native women, but also for other women that come into treatment or into our community programs. Uh, this slide provides more data on some of the issues that face American Indian and Alaska Native women, like the high age-adjusted suicide rates compared to other races. 70% of American Indian women will be sexually assaulted in their lifetime. And in cases where the perpetrators are non-native, sometimes they are not persecuted or are never caught. Removal of children, either through education like boarding schools or social services, lead to broken family ties. And yet, part of treatment and being whole involves or includes those relationships. I'd like to switch gears here and talk about co-occurring disorders in women. Many women that come into treatment or into our community programs usually have one or more substance use disorders, as well as one or more psychiatric or a physical disorder. More men than women experience co-occurring alcohol and other substance dependence. Alcohol-dependent women usually experience co-occurring other substances. A lot of them might come in with marijuana, stimulants, and like we said, we're seeing more women using opioids, and then the prescription drugs. Women with substance use also have higher prevalence of mental health disorders, so being able to assess and dig into both the substance use and the mental health and find those relationships. So a lot of them might come in with anxiety and mood disorders, like major depression, bipolar disorder. Physical disorders in women can also include a rapid development of substance use compared to men. In general, women metabolize alcohol differently and more slowly than men. And because of these differences, the consequences of abuse are usually more severe for women than they are for men. So women have a higher prevalence of liver disorders than men, and a higher prevalence of osteoporosis than women who are not abusers. Sorry, my phone just went off. Other physical disorders that we see in women that are using includes higher prevalence of different cancers like breast cancers, cancers of the oral pathways, and cancer of the digestive tract. For women that abuse methamphetamine especially, dental care is usually limited. Other issues that might be as a result of use include reproductive health issues like sterility, menstrual disturbances, early menopause, early aging. And all of these factor back into low self-esteem, depression issues that those women might already be struggling with. So just being able to tie those in and help those women is very important. So how do we prevent, assess, and treat the women with substance use disorders that come into our programs? In order to do that, we first need to understand what are some of the barriers they have to accessing help. And one of the major barriers, obviously, is their self, not being ready or not feeling like they need help. There's an issue of cost, which for some of our American Indian populations and other populations, it might be too expensive, or there might be unemployment, poverty issues that make seeking substance use and mental health treatment the least of their problems. Feelings of shame and guilt for a lot of women, especially in cultures where being a user is frowned upon or not even considered something that should be talked about. Sometimes family members are a barrier. I've been in communities where someone might go into treatment, and especially for American Indian communities, and they come back into the very family they left, and maybe everyone in that family is a user. And so those become a barrier for seeking treatment. Intimate partners can be a barrier. Systemic factors like unemployment, again, poverty, inaccess to health care can be barriers for women to access help. So sometimes we need to meet these women where they are. And when we talk of practical issues, it could be something as basic as I have 5 kids. I'm a single mom. I don't have time to go for treatment. Who's going to watch my kids? What if my kids are taken? So, and those are some of the things women deal with when they think about, should I go for treatment or should I not? So helping them walk through those is very important. SAMHSA came up with 8 dimensions of wellness for how to work with individuals in treatment. And these include your emotional, your spiritual, your physical, financial, occupational, intellectual self. So being able to treat an individual from the whole is very crucial in helping them stay sober and in helping them in recovery. This is akin to the circle, which is a symbol of balance in tribal communities, a symbol of balance of everything that exists in the universe. The circle is a very important element in a lot of Native American communities. And working in the Northern Plains with the Dakota Lakota, the mental, spiritual, physical, and emotional being of an individual as relates to their community is very important as you're working with them through treatment. I'd like to read an excerpt from Black Elk as was narrated to John Neihat. I'm not sure if I'm saying that right. And that was recorded in 1932 on the importance of the circle. I won't read all of it, but I'll read some of it. And I quote, "You've noticed that everything an Indian does is in a circle. That is because the power of the world always works in circles, and everything tries to be round. In the old days when we were strong and happy people, all our power came to us from the sacred hoop of the nation. And so long as the hoop was unbroken, the people flourished. Everything the power of the world does is done in a circle. The sky is round, and I've heard that the earth is round like a ball, and so are all the stars. The wind in its greatest powers whirls. Birds make their nests in circles, for theirs is the same religion as ours. The sun comes forth and goes down again in a circle. The moon does the same, and both are round. Even the seasons form a great circle in their changing and always come back again to where they were. The life of a man is a circle from childhood to childhood, and so it's in everything where power moves. Our teepees were round like the nest of birds, and these were always set in a circle. The nation's hoop, a nest of many nests, where the Great Spirit meant for us to hatch our children. Again, maybe the last time on this earth, I recall the great vision you sent me. It may be that some little root of the sacred tree still lives. Hear me that they may once more go back into the sacred hoop and find the good road, the shielding tree." So a very important aspect of American Indian culture, at least for the Dakota, Lakota, and Nakota out here in the Northern Plains. And these are some of the things we need to understand when these community members come into treatment. How do we take these elements of their culture and incorporate into prevention, assessment, and treatment to make them whole? Would have been really nice and powerful if that was my last slide, but I like to talk about some of the evolving treatment approaches for women. So where we've come from with the stigma and where we are now. The services for women in substance use treatment has evolved over time. Initially, it was developed primarily for men. A strength-based approach builds on the woman's strength and uses available resources to develop and enhance their resiliency. So that's where we kind of are now. So in the 70s, there was some recognition that women didn't do well in environments that were for men and that they were underserved. And so that resulted in establishments of women set aside for the development of some early programs for women. In the 80s, there was a realization that, well, we have pregnant women and women with children with almost no access to substance use services. So the set aside for women was increased to 10%. And this led to new program models like the 1994 Comprehensive Treatment for Women, Model for Treatment for Women and Their Families by CSAT. In 98, SAMHSA launched the Co-Occurring Disorders and Violence Study for Women, a 5-year study that explored the interrelations between violence, trauma, and co-occurring mental health and substance use disorders among women. From that time until now, we have moved into the gender responsive, which identifies ways to meet specific treatment and recovery needs of all women in different settings. So what are gender responsive services? Stephanie Covington defines them as being able to create an environment through site selection, staff selection, program development, content, and material that reflects an understanding of the realities of a woman's life and is responsive to those issues of that particular client. And I would add the cultural background of that particular woman. Gender responsive principles typically address women's unique experiences. So Jane and Mary might come from the same house, same community, but their experiences are extremely different when they come to treatment. Gender responsive programs are trauma informed. They use relational approaches, are comprehensive to address women's multiple needs, whether it be family, children, intimate partners, and they provide a healing environment of hope. So Stephanie defines what she calls a spiral of addiction and recovery. Think of a spiral staircase as the one on the screen. And we need to view addiction holistically. She describes the interplay between addiction and recovery as a spiral. In the downward spiral of addiction, as in this staircase, we see constriction as you go down. The focus for that woman is the drug. Addiction pulls the addict into ever-tightening circles, choking life until she's completely only focused on the drug, and the drug becomes in charge. In this phase of constriction, the therapist's task, or as community providers, is to break through that denial and help this woman to get to that point of admitting that she's not in control, but the drug is. And usually this is a sensitive and humiliating time for the woman. Especially if you add levels like if they're LGBT and there's that coming out process, if they're an adolescent and are dealing with bullying or self-esteem issues. So it's a very sensitive time, and we must, as providers, understand that a woman who enters treatment at that time comes with a very heavy burden of shame. And we don't need to shame them any further, but we need to offer them the hope that they can heal. And as we work with these women from their unique experiences and helping them through those processes of healing and recovery, the upward spiral, as it goes back up, it expands, and it revolves around the drug in ever-widening circles. And that addiction loses its grip, and the woman's world expands away from the drug to include healthy relationships, a healthy self-concept, and a rich physical and spiritual life. So this process is not just one of turning them around from you're a user to now you're not, but they come up this spiral staircase as a changed, new, whole woman. So they almost ascend a completely different, healthy spiral. And so some of the ways we can reach women with prevention and other community, and men as well, but specifically we're talking about women, it's important to identify and provide targeted outreach to women. So like we talked about earlier, we need to reach our adolescents before they start using with prevention. We need to provide education and resources in different settings, e.g. the family planning clinics in schools, in primary care, for instance. When women come in with, say, domestic violence issues, or they've attempted suicide, or they're depressed, these are rich places to provide those screening tools so that we can identify upfront in primary care women that need to be referred to treatment. And so as community programs, developing those integrated behavioral health programs so that we're not losing clients through the cracks. When they come into the emergency room with a domestic violence issue, it might be related to substance use. Well, if we don't screen them, we treat them for the results of the violence, but we lose them in the substance use treatment that they need. So being able to work with other programs to refer those women, or to even do brief screening to know what they need. In terms of assessments, assessments will help us define the problem, determine a diagnosis, and be able to develop a treatment plan. So being familiar with a woman's culture, beliefs, values, and experiences, individual family needs, priorities, and resources will help us to provide a non-judgmental attitude as we assess them. The assessment strategies need to be very gender sensitive, as well as affirming for those women that are in the coming out process. They need to be sensitive to the culture the woman is from, and they need to be inclusive of some of the needs of those particular women. When working with Native women, for instance, again, it's important to identify their cultural orientations, like we talked about before, traditional, bicultural, or assimilated. And so some of the potential assessment questions we can ask is, how do you identify yourself, traditional, bicultural, or assimilated? Do they practice their cultural practices? And then we can ask questions like, have you ever experienced feelings of inferiority related to your ethnic identity? Have you experienced prejudice from non-tribal members, from tribal members? We really want to know enough about the individual so that we're developing programs that meet those specific needs. We've had stories of people who leave tribal land, and when they come back, they experience prejudice from their own community members. So how do we help them work through those systems with their families and community members? So being sensitive towards their traumas, focusing on their strengths, respecting and supporting them. We shouldn't expect to get all the information the very first time we ask, but as we build that trust, they're more keen to provide more information. So some examples of screening tools out there. For pregnant women, we have TWEAK, a 5-scale program developed to screen for risk during pregnancy. We have TACE, which is 4 questions. There's Addiction Severity Index that has been adapted for use with women and has been adapted for use with American Indian communities. There's screening, brief intervention, and referral, or the screening and brief intervention, that both of which can be used in emergency rooms or in primary care. So assessment tools can be a whole training in and of itself. And so I know the ATTC offers trainings on some of those, so I'm not going to delve into them just in the interest of time. Ooh. When it comes to treatment, again, innate cultural, spiritual resources should be the focus of treatment. Cultural and spiritual information are a normal part of the treatment regimen, especially when working with native communities. SAMHSA has developed what they call a comprehensive treatment model as a guide that can be adapted, and comprehensive programs for different communities. It categorizes, it has 3 categories that have an impact on treatment for women. So clinical treatment services, clinical support services, and community services. So understanding some of the processes of mental health and substance abuse, reducing feelings of shame. In my experience working with the Northern Plains Indians, the Lakota, they have the 7 values of life. And I'd like to read them, each of them in Lakota, and forgive me if I mispronounce or say it wrong. But coming from a different culture, I've also learned that when we translate words from our tribal languages into English, sometimes it loses the meaning, the original meaning. And so in honor of keeping those original meanings of these words that are very important when we're working with Northern Plains Indians, these values that we can ask, how do we integrate these into assessment, treatment, and aftercare plans of our clients? So wochekia, woksape, waohola, wawahwala, waonshila, wawochakie, and wowichake. Important values for Dakotas, Lakotas, and Nakota bands in the Northern Plains. I'm sure other communities have values that guide how they grow, how they function in their communities and with their families. And so incorporating those into treatment is very important. So some of the empirically supported treatments include motivational interviewing, motivational enhancement therapy, motivational incentive therapy, cognitive behavioral interventions, behavioral marital therapy. Again, all of these trainings, I believe, are provided through the ATTCs and require its own hour. Once again, gender-sensitive treatment options should provide a safe environment. In some cases, access to transportation, a big issue on reservation land, should include significant supportive family members. Can be a single gender group or a single gender treatment program. Other pharmacological treatments for nicotine include the patch and bupropion. For alcohol dependence, oral disulfiram, antabuse, buspirone. So just a few that are out there that can be used for medically assisted treatments for women. For cocaine, antidepressants, there's really none for methamphetamine, but for opiates, we have methadone maintenance, naltrexone, and naloxone. There's several publications and programs that have now been put out there for women. For example, this SAMHSA publication that addresses the needs of women and girls. SAMHSA also has, which I've used a lot of their information, a training toolbox for working with women with substance use disorders, and that can be found on their website. Other protocols include seeking safety, the treatment improvement protocols, another one called Treating Women with Substance Use Disorders, the Women's Recovery Group Manual. All of these can be found on the SAMHSA website. The National American Indian ATTC has different curricula too that they've developed for working with women, like the Healthy Women, Healthy Lives, that you can find on their website, or you can call Kate or the ATTC, and I do believe they provide trainings on how to use these. And this particular one has been adapted for working with Native American women with substance use disorders. And one of the interesting or cool things about this curriculum, when I participated in it, they had like a yoga session within the sessions. And in Indian country, it could be resrobics that could be applied. So a very comprehensive curriculum that you can get through the ATTC. They also have the hand-in-hand psychoeducational group program for women with co-occurring disorders, and Kate can provide you with information on that. Well, thank you all for participating. I'm sorry for all the technical issues, but I'd like to acknowledge Kate for helping me through the presentation, and Jenny, and Dr. Shinstad is the Program Director of the National American ATTC, American Indian and Alaska Native ATTC. She's also an Associate Professor in the Department of Community and Behavioral Health at the University of Iowa. So feel free to contact any of those three with any questions, and you can also reach me at my email. Thank you.
Thank you so much, Dr. Liliskoff. That was incredibly informative.
Questions? I see one question. Given the differences in mainstream feminist gender-specific approaches and indigenous conceptions of wellness, what approaches are being used that center indigenous paradigms in assessment and treatment? I think this question is very community specific, but I do know that the National American Indian Alaska Native ATTC is working, and Kate, you can jump in, is working on developing, so some of the tools that currently exist, how can those tools be tweaked to account for the cultural differences, or that can be used in different tribes? So I know one of their projects that they're going to be working on is how to tweak those current existing tools to make them more culturally sensitive to indigenous populations. I also know a particular tribe in which the behavioral health director is trying to develop what she's calling villages of wellness that incorporate indigenous conceptions of wellness based on their traditional values. Are you aware of tools that are based in indigenous knowledges and not mainstream knowledges? Right now, the one that I know is the Assessment Severity Index that has been tailored for American Indian populations, but I can check. I know there's one that was developed by the late Dr. Maki, that I know has not been put out there, but that the ATTC is currently hoping they can actually publish it and use it. But Dr. Maki was Santee Sioux from Nebraska, and he developed a tool that accounted for cultural differences when working with American Indian population. So I know they're expanding those tools at the ATTC. I see Kate is typing more information. Okay, go ahead.
I don't believe Dr. Liliskoff can hear me when I am on, and so I'm going to just try something. One second. Okay. So Dr. Liliskoff, thank you so much for sharing that. I have muted you now, so you can maybe turn on your speakers without having that echo effect, and then hopefully you can hear what I'm saying. But as she mentioned, yes, a lot of our work here at the National American Indian and Alaska Native ATTC is to take what's currently out there in behavioral health evidence-based and evidence-based practices and and do some cultural assessment and make them fitting for tribes, and we work closely with tribes to do that work. So that is something that we will continue to do in the next few years as we continue on this grant. So yes, I wanted to encourage you all to get in touch with us if you want to have trainings in your area on some of this, and we will continue to do that as well. So with that, I want to thank you all for joining us, and we are. I just want to remind you that we are recording this, and so I will be sending out a link to this recording as well as handouts of the slides to everyone who attended. And we also have a survey that we will link you to as we finish out here. So we would greatly appreciate your participation in that, so we can get an idea of what you thought of today's presentation. And someone just asked about the CEU request form, and that can be submitted. It does require a check, and so that has to be mailed in. And so the address is on the form, and you'll find that in the files pod, but we'll also send that out in our follow-up email. So look for that. And with that, I think we will close out. So I want to thank everyone again, and thank you so much, Dr. Liliskoff, even though I don't think you can hear me, but We thank you so much for sharing your expertise with us, and hope everyone can join us again next time.